Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in optometry. Discover a new show at itube.net/podcasts.
Hey everybody, welcome to another episode of your podcast to help you sleep at night when the rain sounds don't work and when your snoring spouse isn't doing it for you. Just throw in a little collaborative corner of the podcast and let it hum in the background, because God knows that's what most of us are doing. You know, I'm excited about this week because the guest that I have actually is kind of making me feel a little nostalgic. I actually was just at the Academy where it was in Boston. So I went to the New England College of Optometry, otherwise known as NECO. Realized that I graduated there 31 years ago. My Lord, I'm telling you. And back then, you know, my idea of optometry was spinning and grinning, which is better, one or two. And more importantly, I did a residency and a clinical rotation at a cataract and refractive surgery center in Arizona. The weird and exciting thing about this is that it was a cutting edge cataract and refractive surgery center. And whereas in Boston, we were doing, you know, extra caps and, you know, cutting sutures and it was insane. You go out and we're doing small incision, phacoemulsification procedures.
Mark, what year was this? Was this like 1945, 50?
Yeah, that's beautiful. I didn't even get to introduce our guest. This is, if you can tell by the voice, it's Dr. Nicholas Bruns. It's Bruns, right? Not Bruns.
You got it.
Nicholas Bruns. Nicholas is coming from Summit Eye Care, Wisconsin. And so, Nicholas, what I was going to say to you is that while I was there, this is 1994, 1995 is when we started doing black box laser. More importantly, it was the Barnett Delaney Eye Center. We were one of the first clinical sites for the Staar Surgical ICL. So we were actually doing the clinical investigation. We did the phase 2 for hyperopia. So interestingly enough, we had people that were basically amblyopes greater than 2200, and we were putting it in the hyperopic lens. But then we also did phase 3, and we also did the toric ones. And the exciting thing is that the clinical investigator, as you very well know, who was the primary clinical investigator for the Staar Surgical for the ICLs, Nicholas?
It was John Vukic, my clinic partner.
John Vukic from Summit Eye Care in Milwaukee, Wisconsin.
Oh, yeah.
So it was kind of exciting because one of the very first meetings I ever went to as an OD and kind of like a KOL, and thought I was kind of hot shite, was at the Edgewater. Now, a lot of you don't know Madison, Wisconsin, like us over here, but we do. And the Edgewater, it was wintertime. So we go to this meeting to go into the Davis Durandine clinic and where John was working at the time. And then we have a meeting, and I sat next to this young upstart optometrist who worked in Kansas. And his name was, what was his name? Paul Specky or something, Paul Karpecki. Yeah. And so Paul and I are looking there, and we're looking at like some of the older ODs that were there. And Paul looked at me and goes, you know what? That's going to be us one day. And here we are, full circle. I'm the old guy sitting here talking to the new upstart young guy who's in a practice that's super progressive. So Nicholas, before I ask you, Nicholas, I want to kind of bring this in, and I like calling you Nicholas. Just, you know what, that's your name. I like it. What I was going to say, though, is that a couple of things that I was thinking about before I realized we were going to be talking is, one, how we're still searching for those procedures to help our patients, and having progressive practices that are willing to basically do the clinical trials or to think outside the box. We did, I think we did 9 or 10, clinical investigations for refractive procedures. I personally have been involved in about 25 myself, but it makes me think of things like, keratopigmentation surgery. I mean, just the notion of a surgical procedure that basically alters the color of our eyes. It's just Crazy. Are you guys doing that over?
Oh yeah, all the time. Yeah, we do that all the time for sure.
Yeah.
You know.
Well,
No,
what's funny is that Brian Boxer Walkler, who he's like a freaking mad scientist. And if Lee Nordan, you got to look this up too. Lee Nordan back in the day was kind of a similar person where he would just do things to just be irreverent and just say, because I can, I got to try to do it. Brian's been doing, keratopigmentation procedure in his practice in Beverly Hills for a while. It's just crazy. It's crazy to me.
it's interesting. I don't know. Sometimes just because you can doesn't mean you should. But John, my clinical partner, he's taught me everything he knows in the last 6 years, and we've gotten to know each other very, very well. I describe him as conservatively aggressive, aggressive to the point where you definitely want to be out there. And it does take some risk to be on the forefront of things. But being aggressive for the sake of being aggressive isn't always a great thing. You want to make sure that the data supports it, that the product that you're using, the implant in the ICL's case, is safe and it actually can provide benefit, especially in something that's completely elective. So, way back then, I mean, when I came to John, we met each other, long story short, we met each other in early 2020, and which was a perfect time to start a practice. We started,
Oh, absolutely.
yeah, it was great. It was just, man, great time.
Everybody
But he
was at
said,
home. It was good times. Yeah.
yeah, he said to me though, he's like, "Hey Nick, do you want to be on the podium? Do you want to speak? Do you want to get involved with industry and do stuff?" And I said, "Hell no, man, not at all. I don't want to." And I thought I wasn't the right guy for him for whatever reason. What he saw in me was somebody who did have a motivation to get involved. And then once you get your foot wet just a little bit in new technology, you realize actually this is pretty cool. And we are making a serious impact. So ICL, for instance, I mean, that's a big part of our practice. We do a lot of them. Premium lenses, light adjustable lenses are a big, big part of our practice. You start to see that, oh, these things aren't experimental. They're studied, they're established, they're safe, and most importantly, they make a huge impact on patients' lives. And you're making a difference. And that's the biggest thing that he has taught me, that yes, they're new, but they're studied, they're established, and they make an impact.
It's interesting. Let's focus a little bit on refractive surgery. Back when I first started practicing, it was PRK, RK. We were doing slash for cash, and then it moved on to PRK. And then when LASIK came to the States in like '97, we were actually doing black box in 1995, 30 years ago. And so I almost kind of feel like people still synonymously think refractive surgery means LASIK. When the ICL came out, in the mid 2000s, there, it's been around for a couple decades too, but it never really picked up. But I've always felt that procedure has the opportunity to just kind of be the best. To pretend I'm a patient. How would you? I come in for LASIK, and I'm like, how would you talk to me about what the advantages are of the Collamer lens, the EVO technology?
Well, LASIK has been around for 30 years, and in a nutshell, it is very similar to what it used to be. We've gotten a lot better at it, especially controlling higher order aberrations, which are, a way of measuring the quality of the vision rather than the quantity. But there's a reason why somebody who's highly nearsighted would benefit from an implantable lens instead of a corneal refractive procedure. And that has everything to do with, well, two big things. Number one, the nodal point. We all know what the nodal point is. You went through optometry school. Mark, I know you went through school back like 60 years ago, but the nodal point is the center part of the optical system of the eye. The closer you can get to the nodal point, the better, at least theoretically, your vision's going to be. But LASIK, at the end of the day, it's a dose-dependent procedure, meaning the more nearsighted or farsighted that you are, the more altering to the corneal tissue you need to have. Now, we know that altering corneal tissue comes with negatives. And number one, higher order aberrations. That's a part of it. Number two, dry eye, things like that. And then once we eventually or inevitably approach cataract surgery, the fact that you've permanently had your cornea altered affects how we do cataract surgery, and it affects what implants that we have available to us. Somebody who's had LASIK before, we may not be likely to do a multifocal or a depth of focus lens. We may have to stick towards a monofocal, which limits patients' options. So EVO ICL, or ICL specifically, is going to be, it future-proofs your eyes. It gives you the opportunity to have higher level of correction and spectacle independence later in life. LASIK, doesn't always. It does change things.
So it's interesting because, the reason why we always talked about doing PRK was because, you're sparing the center part of the cornea. You're not, well, no, you're not really not sparing the center part. You're doing less treatment, but, with the ICL, it's tissue sparing completely. And I was fortunate enough to work with a lot of really smart people, as you have been. And George Waring the third basically kind of like drilled into my head, which it's so true, is that this is the most non-invasive procedure. When you think about LASIK, you make a flap, you're going all the way around, maybe, you leave the hinge, we're using the intralays, the femtosecond laser to make the flap. So, we have that precision, we have the consistency, but you still have to then remove the tissue, and then the tissue has to regenerate. That flap is useless tissue now. When you do an implantable collamer lens, and the EVO, which basically has that small port in the very center to allow the aqueous to basically go front to back, so we don't have to do the iridotomies anymore, you're making a 3mm incision, and that's all you're doing, that tiny 3mm. So you're doing, completely, it's the least invasive. And I love that when I talk to patients. What do you think the reason is why, when given a choice, LASIK or EVO, why patients are more apt to go the LASIK procedure?
Well, there's two reasons. It boils down, no matter what kind of conversation you have with your patients when you're talking about options. And we do a lot of LASIK too. So I don't mean to talk negatively about LASIK. I like LASIK for the right person. But it comes down to either fear or its cost. And cost, LASIK does generally, on average, cost less than EVO ICL, and that's just because of the nature of the procedure. EVO ICL, like you said already, I mean, we think of it as more invasive because you're going intraocularly, and while that does carry maybe some risk, we're not taking anything out. Now, we've been doing cataract surgery since the mid 40s, in the current state that it's in, where we take a lens out, put an implant in. With ICL surgery, we're not taking anything out. So the amount of energy that we need to use while we're in the eye is rather low. And it's a 3mm incision. It's not that big. LASIK costs less. It is a topical procedure, but arguably, like you just said, Mark, it's more invasive because you're taking tissue, you're altering it, and you're removing tissue. So it comes down to fear or cost. Fear, that conversation it's easy to have. The data proves it. The FDA trials and all the published literature looking at the EVO version versus the legacy ICL. Now, if you actually look at that, the legacy ICL did require having a laser peripheral iridotomy or a surgical iridotomy during surgery to reduce or eliminate the risk for pupillary block and angle closure and premature cataract. The number of complications that the legacy ICL had is certainly not zero. We saw them in our practice. You do enough of them, you're going to have complications. And it's really tough to have a healthy 20-some-year-old patient who had an elective procedure come in with pressures of 70. We've seen it, done it. Not fun.
Been there, done that.
Yeah, I'm sure you have. You'll remember those days. I remember my first one. It was a phone call at like 5 a.m. It was a girl who was 25 years old, and she called. She was in tears and she's vomiting. I'm like, oh shoot! I was running on the treadmill at the time. I was up early. I had a young kid at the time, and I was like, ah, shoot! Let me shower real quick. I'll meet you at the clinic, and we got her taken care of. But I will always remember that interaction. Anyways, I digress. The EVO has that central port in it. And so because of that central port, we no longer have to do iridotomies. There is there's zero incidence of premature cataract. And I think there was one case of pupillary block in the published literature, and that was just retained viscoelastic. Essentially zero. So the big risk that you saw with the legacy ICL, you do not see anymore with the EVO ICL. And so then it comes down to cost. And that conversation, right? We are at the end of the day trying to provide benefit for our patients, but we want to make sure our patients understand the value of a procedure before we get down to the dollars and the cents. And our practice, we're very transparent with things. I don't lie to them. I want to make sure they understand that, yes, this is more expensive, but while it carries a higher price tag generally, if I'm bringing it up to you, it's a good idea. Now, we could do LASIK, but you may want to consider an alternative. And this is why we like it. It costs this much. And if that's too much for you, then maybe refractive surgery is not a good idea after all.
Yeah, I always enjoyed being able to say to a patient, look, you know what? I'm not here to sell you something. I'm here to tell you what's in your best interest and let you make that decision based on our clinical acumen. What is your cutoff? Because so the EVO is what, -3, right? So anybody below -3, it's a non-starter. But at what point do you say, you know what, we're not even going to mention LASIK or PRK?
I mean, once you get to like even 6 to 8 diopters, I definitely don't talk about LASIK too much. It kind of depends on the anatomy. It depends on the age of the patient, the corneal thickness. But once we start approaching 6, I strongly start recommending EVO compared to LASIK. And admittedly, when I met John 5, 6 years ago, I didn't know what ICL was. In my previous practice, I worked in a heavy refractive practice. We did a lot of LASIK, a lot of cataract. We did not do ICL.
Blasphemy.
I know. And I keep calling back like, hey, you guys doing ICL yet? You should be. Anyways, I talked to John about it, and he's like, well, we do this new thing called ICL. And well, it's not new at the time, but it's something I had never heard of. So in my mind, I've got this Venn diagram, right, where I've got LASIK on one end and then the high myopes, my -12s, -14s. Like, we're not going to touch you with a laser for obvious reasons. So that's our ICL patients. But over time, as I've accumulated happy patients, over my years here working in Wisconsin with John, that overlap is way bigger. So anybody over -3, I talk to them about EVO ICL. Now, it may not be in the cards for them, or they may be a perfectly fine candidate for LASIK. And again, I'm not trying to sell anything. We net the same amount of money no matter what procedure we do. And I'm not a salesman. I'm a doctor. I tell patients all the time, it is in my best interest to have you happy. Mark, I'm sure you've had at least one unhappy refractive patient, right?
You mean today? In the first hour, or yeah,
It's part of
because
the territory.
it's expectations. I mean, and the one thing we can't manage, we can have a great procedure, but then a person's expectation or perception of what their expectation is, that John Potter 20 happy, I freaking love those patients. So you're dead on. It's like, we want to make this so that you're content because our lives would be content too. Totally agree.
There's a psychology to this. There really is. I want my patients to be happy. 20 happy is a very real thing. I want them to be happy because at the end of the day, this is not like cataract surgery. Cataract surgery patients come with a problem. They come with an active problem that they need to be fixed. And so we're here to fix it. LASIK patients don't really have a problem. I mean, it's a lifestyle problem, but they're functional. ICL patients or LASIK patients, but it's an elective procedure. So I don't want to do something that is going to set you up for failure, because if you're not happy, you're my problem to deal with for a long time. And that makes my life a lot harder.
I love that for yourself, especially when you got to get home and play with Oakley.
Of course.
So,
Yeah.
wait, is Oakley still around?
Oakley's still around. Yeah, he's like looking at me right now through the door.
Anybody doesn't know, Oakley's he's an Irish setter. What is he?
He's a 8-year-old yellow lab, but he has the energy of a 6-month-old puppy.
Yeah. So, all right. So I'm going to reverse course, drop it, flip it, reverse it, but at the same time, we're going to stay on course here. Many of our 2 listeners know that we just had another presbyopic drop that actually made it into market. Vuity was out there for a little while, a little pilocarpine. Closey is out there, 0.4% pilocarpine. It's a do as you wish, once a day or twice a day, personalize it with less side effects than the original pilocarpine. But then very recently, Viz from Lens just came with their samples. They're doing a little bit of a slow rollout, but aceclidine is a whole different molecule, 1.44%, which really has the opportunity to give us subpar pupils below 1 subpar. What I mean is like really tiny pupils, like that's not subpar, 1.5 millimeters or less, 1.3 on average, give or take, which gives that depth of focus, gives that opportunity for patients. Now, working in a cataract and refractive surgery center, I believe, have noticed a shift in the amount of patients coming in for clear lens extractions, refractive lens exchanges. I venture to guess that your LASIK and EVO volume is either equal or even a little less than your clear lens extraction because of the opportunities. So I'm going to give you a two-part question. First, do you think that having a presbyopic drop that actually really does work, it was clinically tested on pseudophakics and post-refractive patients, do you think that that is going to change how you talk to patients about their clear lens extraction choices? And two, walk me through a little bit about your thought process on making those patients who you said, and I'm going to quote you, the cataract patients don't, they have a problem. The problem also is that they see all their friends who've had it done and threw their glasses away, and they're seeing like they did when they were in their 20s. It's kind of like Cocoon. They're all jumping in the lake. I know I just made a reference from an 80s movie, and most of you are going, I was born in the 90s and the 2000s. I don't even know what he's talking about. Oh my God. I just had this, I had this patient where I said something about Fast Times at Ridgemont High, and they go, what is that? I go, it was, don't you remember Spicoli, dude? And they're like,
Classic.
no. Yeah. And it's like, when were you born? He goes, 2010. And I'm like, wow, you're dead to me, kid. So, all right. So my second part of the question. So first part of the question that I asked you was, how do you see, having a drop? Is that going to change anything for you? And then second part is, talk to me about your presbyopic options, because those patients who are clear lens and cataract kind of want the same thing. They want ridiculously seamless functional vision.
So I could probably answer both of those the same way, and I'll kind of give you a little, long answer here, I guess. The ability to have a drop is, for lack of a better way of putting it, it's just having another tool in the toolbox. And to having a drop that is functional, it arms me with opportunity to help my patients. Like I just said, refractive surgery, cataract surgery, there's a lot of psychology to it. The patient that I hate seeing, and you probably do too, it's the 50-year-old plus 75 patient, because those patients, they're really tough to please. They have a problem. They come in with the inability to see their phone, their text message, where we all have our computers in front of us all the time, and they're struggling to see those patients because they're an emerging presbyope with a low hyperopia, and the distance is okay. So it's a patient who comes in with, I don't wear glasses at all except for reading. And what am I supposed to do there comfortably for that patient where I can say that, yes, this will make you better? It's not like with a minus 12 patient coming in where I can say confidently that, oh, EVO ICL, this is going to make you happy. I know that. Those patients are tough. A low hyperope, pre-presbyope or early presbyope, those are challenges. So having a drop available, I don't want to do surgery on somebody who has anything less than 100% chance of being satisfied. So giving a drop, it's a conservative approach, and it generally works very well for that exact subset of patients. So closely, I've got a lot of familiarity with. I don't have a lot of familiarity with Viz. So I'm looking forward to getting my hands on it and trying it. But that option is just, it's what we need in the refractive space. We need something that works. Now, Vuity, we had Vuity, and Vuity did work. I think it was a masterclass in what not to do marketing wise, but it did work. And so the small pupil or the pinhole effect that the meiotic agent is going to do is it helps. It does increase depth of focus. It reduces higher order aberrations. It comes with very little side effect, maybe a little bit of a brow ache sometimes. That's generally, transient and goes away. But having that opportunity, I think, is just, it's huge. And we're looking for that. Now, on the flip side, patients who have gone through cataract surgery, most of our lenses that we have available, if I'm planning a surgery, my goal for most people is the distance. I want to nail the distance. And then if we're able to get depth of focus, that's extra credit. I'm never promising somebody that you're never going to need reading glasses. That is not in my vernacular. It's not what I say. I tell them that it's likely, no matter which option we choose, you're probably going to need reading glasses for small print, especially in low light. Well, now we have an opportunity to, again, use the same drop in those patients, because those patients tend to function just like a low hyperope. Those are very similar patient categories. And it's, again, just another tool in the toolbox. Is it the magic drop? Is it going to completely eliminate glasses for everybody? No, it's not. We do not have the holy grail yet, but it is another tool in the toolbox. So long answer, I think answering your questions. Did I?
Yeah, you did. I mean, but talk to me about, who are you looking at for, let's say, a multifocal or a light adjustable lens. What's your thought for the, because I know you guys are involved in the clinical trials for the light adjustable lens. And to be fair, we do it in our practice as well. And I've kind of, I think you have a lot more experience with the lens, and maybe have a little bit more nuances for me, because um, I felt that there's a difference between the opportunities with patients with light adjustable, because it's almost that modified or monovision in a sense. Conversely, with like a multifocal lens, where the side effects are going to be the glare, the halos, but you also have the opportunity to get that full range. So to give my listeners, I keep expanding, right? I went from 2 listeners to my listen. You know what? I love every one of you. If you guys are awake, wake up now. Is that give me the 10,000 view discussion about light adjustable versus even. Let me digress. Okay, I know I'm spinning up here. I had a patient today that said to me, "Why did I spend this much money when it feels like I could have just got a standard lens?" So talk to me.
Why? So the category of premium IOLs, the patient that I'm looking for is generally the active adult. It's somebody who has a lifestyle need and a reason to get out of glasses. I never want to push somebody towards a premium lens if they're happy with their glasses and they prefer glasses. So they have to want it. If they want it and that matches their lifestyle, then awesome. This opens up a conversation then. The conversation now becomes, well, do we do a multifocal lens or do we do an adjustable lens? And, multifocal or extended depth of focus, we have great options on the market now. I mean, especially in the last couple of years, we've just got so many different great things. But those lenses at the end of the day are fixed lenses. And what I mean by fixed is that once you put them in, you get what you get. And then if you don't like the outcome, well, then you're looking at either, one of 3 things: glasses or contacts, LASIK or PRK touch-up, or an explant. And those are very real things that might need to happen for patients if they're unhappy with the lens itself, whether it be from a refractive miss or the glare and the halos they just don't neural adapt to. That lens may need to come out. And now we're looking at subsequent risk. Opening the eye back up, taking a lens out again, and putting a new one in, that is added risk. So we do those lenses in our practice. We do a significantly more amount of light adjustable lenses. And because, well, there's a lot of reasons why, but a big part of the reason I think is patients are very vulnerable when they go through cataract surgery, and the element of control is extremely appealing to them, where they want to have a say in what's going on. And I tell patients when I counsel them on the light adjustable lens that, this seems like a lot of work. It does. It takes about 6 to 8 weeks to get through the process. And during that time, you're functional. But the feedback that you provide during that time when we're actively doing the adjustments is a critical part of it. So if you want to have a say in what we're doing, if you don't like a part of your vision, we can manipulate it. We can adjust it. I get that comment all the time, Mark, where I tried monovision in the past and I hated it. I don't like the term monovision here, because monovision, like in contact lenses, implies that your eyes are completely independent. It implies that you got one eye for distance, you got one eye for reading, and they don't have a whole lot of overlap. Well, calling the light adjustable lens a monofocal lens is like calling the Mona Lisa just a painting. It's not a monofocal lens. It's a aspherically blended lens. So what we end up doing with our mini mono or our blended vision is we do one eye set for plano. Typically, we're doing the non-dominant eye for -1, -1, -75, sometimes maybe -1.25. But you're preserving binocularity, you're preserving depth perception, and you can allow neuroadaptation to take place over time before you commit to things, which is the absolute beauty. So to your patient that said that, well, why did I pay all this money for something that I could have got a standard lens and had just as good of an outcome? Sure, you could. But it's like saying, well, why did I pay so much just to get the ball in the hole when let me cancel that. That was a bad analogy.
I want to know where you're going with that, but
So
let's do
I
a
was trying
different
to
analogy.
say, I use a golfing analogy all the time, and I'm getting ahead of myself. So I use a golfing analogy all the time. A light adjustable lens is like having the ability to putt. A standard lens is like hitting the ball one time and just being satisfied with it on the green. Could you hit a hole in one? You might. That's a lucky shot, but you might. Wouldn't it be nice to have the putter in the bag and be able to putt it 3 times? The outcome is the same.
I like
If
that
you're,
analogy. I
yeah. So
mean,
you're
but so you had said that it's an aspheric lens. Is that the
mhm.
LAL plus?
the,
Um,
the LAL is slightly aspheric too. So it has a little bit of negative spherical aberration in it, which, for patients who have a high amount of negative spherical aberration to begin with on their cornea, that may not be the best fit. But the negative spherical aberration, especially for somebody who is either post myopic LASIK or regular corneas, even irregular corneas, it works very, very well. That provides added depth of focus. The LAL Plus is very similar to the LAL with just a little bit more added negative spherical aberration to it. So we use that lens for people who have perfect corneas. Just like we use a multifocal lens, we use the LAL Plus in those patients, and it still provides the added element of control.
it's interesting you brought up the fact about high order aberrations. I actually did submitted a poster. This is what I was partially doing at the academy, using a phentolamine ophthalmic solution. The abbreviation is POS. Every single time I have somebody read the informed consent, they're like, it says POS, POS, and I go, I promise you, it's not a POS. It's phentolamine ophthalmic solution. But that is also another miotic. And the interesting thing is that we're using it for patients who've had LASIK or PRK corneal refractive surgery that have glare at night. And so using this as a way to reduce some of the glare, the halos. So I think that in itself sometimes becomes problematic for patients. And now you have an opportunity to let patients kind of manage those. So I'm kind of excited about that. Is there anything you're excited about coming up? Anything new? Anything you guys are working on over there at Summit Eye Care?
Yeah, technology wise, I mean, nothing crazy that I'm super excited about that's in the immediate future. I think the holy grail of the accommodative IOL is there. I mean, there's a lot of stuff in the pipeline about accommodative IOLs, and we've had an accommodative IOL in the past, and it didn't provide what we thought it would. But that is the holy grail. I think if we can find a lens that fully accommodates without any visual compromise, it's coming. And I'm hoping by the time I'm ready for surgery, it's there. Otherwise, I mean, just continuing to utilize what we have, the EVO and the LAL are two big parts of our practice. And those two lenses, I mean, refractive surgery is as much of an art as it is a science. Ask anybody. The ability to use the diagnostics, and I think improved understanding of higher order aberrations. That's where the diagnostic world is going in refractive surgery. And then LASIK, I mean, controlling higher order aberrations. So those are the things that are, we're not there yet, but we're getting there. And I think those are really exciting technologies.
It is. And Nick, you sound excited about this. And the one thing I'll leave everybody who's listening with is you may not think that you have a role in this, and you're 100% wrong, because everything we talked about, everything has to go through the cornea, and everything going through the cornea goes through the ocular surface. So if you're not managing the ocular surface to the best that you can, the quality of the LAL, the quality of the multifocal lenses, the quality of LASIK or EVO is just not going to be there. So it's really, really imperative that you just do your best to help patients walk through this, especially in these crazy times. And, find a surgeon who's doing good stuff. Let your patients, get it here from the best. So Nick, thank you for your time.
Absolutely.
Take care, everybody. And thanks for joining us.